Aduh, Assalamualaikum warahmatullahi wabarakatuh. Semua ada dah ke?
Waalaikumsalam warahmatullahi wabarakatuh. Rasanya dah ada.
Okey, kalau semua dah ada, boleh je lah. Boleh kita start lah. Kita mula dengan Al-Fatihah. Okey, boleh start lah.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. My name is Ni'al Musawa bin Muhammad Hamran, and I will be the first presenter. I'll present the blood culture and sensitivity test. So the definition is, this test is a lab test, is a laboratory test in which we take a peripheral blood from the patient to be tested to see for any presence of microorganisms such as fungi or bacteria in the peripheral blood of the patients, and we culture it in a culture media. So it is a very important procedure which is important for us to determine the diagnosis as well as to determine which type of antimicrobial treatment is appropriate. And when should we do this test? Is when we suspected for a patient to have septicemia or sepsis, and it is usually done soon after the onset of the clinical symptoms, because if we delay it for much longer time, so the bacterial load in the peripheral blood might be poor, and the detection the bacterial load might be low and the detection might be poor. So we do this also before we administer any antimicrobial therapy to prevent for any resistant cases. And what volume should we take? Usually in adults is about 20 to 30 milliliter, with approximately 10 milliliter per bottle. We have two bottles, the anaerobic as well as the aerobic bottles. So, but for children or infants, it is not safe for us to take large amount of blood. So we need to we need to calculate the patient's weight, as well as we need to know exactly the total volume of the patient's blood before we can take blood from the patients. And we usually take as much as 4 to 4.5% of the known total volume of blood. So the table here is shown for blood volumes, which is suggested to be taken for children, whereas the diagram below it is to show the correlation between the volume of the blood taken from the patient with the detection sensitivity. And where should we do? Usually we do through collection of blood through venipuncture at the medium cubital vein in the intercubital fossa. And we avoid taking from other sites, especially from the femoral vein, because the risk of contamination. And also taking from central venous line or arterial line may lead to a false positive results. And there are sites where we shouldn't do venipuncture. For example, is femoral vein, as I said before, in veins proximal to an existing intravenous cannula, because this might lead to an interference in the interpretation of the result later on. Areas in the areas of broken skin and erythematous or bruised skin, and also in pre-existing medical conditions that prevent such as the lymphedema or arteriovenous fistula or stroke that prevents the particular limb to be, that impedes the movement or the usage of the particular limbs. This is the equipment that need to be that are needed in this procedure, and this is also one of the equipment also very important, which is needed in the procedure also, laboratory request form. So first we start off with the explanation as well as gaining consent. So we need to explain first so we need to confirm the identification first of the patient, and then we need to explain the procedure, explain the risk, and also we need to ask for any medical history as well as needle phobia, and we need to gain consent from the patient itself. And this is a video of how we need to how blood culture collection is done. So first, we need to introduce ourselves, who we are, to the patients, and we need to confirm the patient's detail. We need to ask for patient identification numbers, names, date of birth, and so on. And then we need to explain the procedure, and also gaining consent from the patient. And then we need to, the first is to don the apron. Also, we need to sanitize our hands. And at this moment, it is optional to wear gloves at this moment or not. Then we need to clean the tray. I'm sorry. Yeah. So, just before, don the gloves and sanitize the hands. And then we need to clean the tray, also the equipment appropriately. And at this stage, we need to attach the blood collection system. But some manufacturer already came with complete attachments. Okay. So, and then we need to remove the bottle culture cap with assuming of an aseptic touch. Then we need to clean the top of the bottle using the cleaning swab. And we need to repeat the process for each bottle. Next is we need to position the patient's hand appropriately and comfortably. And we need to apply tourniquet to the patient's hand. Say apply tourniquet to the patient's hand. Then at this stage, we might ask the patient to clench his or her fist to make the veins much more visual as well as easier to palpate. Identify the suitable vein. Then if you're not wearing gloves at the first moment before, we need to sanitize our hand, also don gloves. Then here we need to clean the venipuncture site using a cleaning swab and allow it to dry before proceeding with the venipuncture. Then from here, we can use our non-dominant hand to have a grasp on the veins a little bit distal to the side of the venous puncture to make us easier to insert the needle. Insert the needle gently. And, oh man, sorry for that. So insert the needle gently until you feel no resistance, which means that the needle is already getting inside the blood vessels. And then we need to attach the aerobic first. We need to fill up the aerobic first. Just attach it to the blood collection adapter here, and we need to fill approximately about 10 milliliter. After finish, you need to detach the bottle from the adapter and continue with the yes, doctor.
Sorry to interrupt. Again, actually it's my mistake because I didn't actually review your slides beforehand.
Okay.
But where did you get all this information? I mean, what is your reference?
Websites actually.
Which website? Hello, Nick.
Yes, doctor.
Okay, which website?
From geekmedics.com.
That's a problem. That's why we have to be careful in your referencing now, because this is not what we do in pediatrics. I don't think anywhere in the world we do this. Just imagine lah, this is what we call vacutainer lah. Not many hospitals in Malaysia use vacutainer in the first place, even in pediatric or in adult. So what vacutainer did is actually it creates vacuum and it sucks out the blood. Okay, so this is not practical in pediatric, because just imagine lah, pediatric nerve vessel is very small and very weak, so you won't get blood. Okay, the vein will collapse. So most place we don't use this method to take blood culture or to take blood. Okay, we do use butterfly occasionally, but we don't use vacutainer lah. Especially in neonates or in baby lah, in small babies. Okay, in pediatric we usually use either drop method, or it has to be drop method lah. It has to be drop method. Because if you don't have a vacutainer, you need to use drop method rather than vacutainer lah.
Drop method.
So I think drop method, especially for blood culture, and neonates memang kita tak guna aspirate new method, we use drop method. So I think may I suggest you like to review or redo your slides?
Okay, sure thing, doctor.
Okay, and then present it again maybe like tomorrow or the day after ke?
Or maybe we can maybe I can do this again in the next session, doctor. We have another session next week. Yes.
Next week, okay, that's good. Siapa yang dah prepare slides, siapa yang ada slides yang dah prepared, who's supposed to present next week, boleh you present hari ni ke? Kau boleh, kau tak boleh tak apalah, we stick with what we've got. Tapi because this happened again and again, I know it's my mistake, but I don't have time to actually to review your slides beforehand. But the same problem occurs in the previous groups. Okay. When you're presenting procedures, it has to be specific to pediatric. I know it's very difficult to find videos on blood culture in pediatrics, but ideally it has to be pediatric. If you don't have the video, it's okay, tapi the step by step mesti pediatric punya relevance to pediatric lah. So I think tak apalah, you present again next time, okay? And the reference, please guys, use a established reference, okay? Because we know, for example kan, from the word that you use, from the description, most of the websites kan yang students suka guna ialah website yang meant to actually for lay people lah, for lay person. rather than for doctors. So you tend to use words like, I remember last week ada one of your colleague present brain swelling. We don't use this kind of word in medical. We use cerebral edema. And then when you talk about antiseptic, try to use the name because there's a lot of antiseptic. In fact, there's a lot because I did my review on antiseptic, so there's a lot. Okay, in fact, in neonates alone, we use at least I think 10 antiseptic with different concentration, different dilutions. Okay, and in older children lagi banyak. There's a lot. So try to use specific because each concentration is different tau. For example, in neonates kan, you cannot use maybe you use chlorhexidine, but maximum 2%. You don't use more than 2%. And usually in 70 to 80% alcohol. And then the alcohol is different. And then you don't use povidone iodine in neonates. Even in young children, you don't use povidone iodine. So you have to be specific. Like in pediatric is very particular. We are very particular with this, no? So tapi you present again next week. Next session. So Yalin boleh tukar lah, boleh proceed eh. Okay.
Bismillahirrahmanirrahim. My name is Atika and I will talk about continuous bladder drainage. So next slide. Can you hear me? Okay.
Yes, we can.
Okay. Can you when we talk about the bladder drainage, it means that we are talking about urinary catheterization. So these are the equipments that we need during this procedure. So sterile dressing pack, sodium chloride, catheter of right size according to age and weight, and sterile gloves for the clinician, sterile lubricating local anesthetic gel, sterile drainage system, correct size of syringe, correct volume and pool of sterile water, and also hypoallergenic tape. Next slide. Okay, so there are many different types of catheter. So the first one is indwelling catheter, or also known as polycatheter. The other catheter is condom catheter, also known as external catheter, and also intermittent catheter or short-term catheter. Why short-term catheter? Because this catheter we use for only about 5 to 10 minutes. So indwelling catheter is commonly used in hospital setting in a short time and also can be used in a long time. So it is most oftenly inserted through urethra, or we call it transurethral, and sometimes through a small incision through abdomen, or we also call it a suprapubic catheter. The condom catheter has no tube placed inside the penis. Instead, it's just like a condom device. For intermittent catheter, it is used for the self-catheterization. Next slide. Okay, so these are the pictures of different types of catheter. So for indwelling catheter, we have the drainage bag, drainage tube, also a port for balloon inflation and deflation, and also catheter. And this catheter can be secured at the leg. For condom catheter, just like an external use, and intermittent catheter, it only like a single catheter and simple catheter. Next slide. Okay, so we need to use correct size and length of catheter. So in the tables, it shows that a different size of catheter is used for different age and weight. So for the length, we use for a standard length of 40 centimeter for boys, and female length for 20 centimeter can only be used in girls and prepubertal boys with extreme caution. Why we need an appropriate length? Because we do not want to inflate the balloon inside the urethra. Okay, next slide. Okay, so these are the indication. For the indication of catheterization, we use for the acute or chronic urinary retention, facilitate bladder irrigation. Bladder irrigation is where you flush the sterile water to make sure that urine flows without any blood clots, and that will obstruct the urine flows. And then we use also urinary catheterization for acute measurement of urine output in critically ill patient. We do this hourly, and fluid management for daily urinary catheterization, and also during surgery to assess fluid status and prevent bladder over distension, surgery or genitourinary tract management of immobilized patient, such as in case of stroke, and also pelvic fracture. Sorry, next slide. Okay, for a contraindication, we have absolute contraindication and also relative contraindication. What is absolute contraindication? Absolute contraindication where we must avoid to do the urinary catheterization because this will cause a lethal complication if done. So for the absolute, we have the presence of urethral injury. For relative, the urinary catheterization still can be done, but with extreme caution and counseling from the specialist. For relative, we have the urethral stricture, recent urinary tract surgery, and also presence of artificial sphincter. Next slide. Okay. So the procedures, we have the preparation phase and also the catheterization itself. So for the preparation, it is about the clinician form a good rapport between the children and also the parents and or caregivers. So the doctors will discuss about these procedures and gain informed consent from the children or parents. For the children, it is according to the age, whether the children can cooperate or not, can understand. And then we have the doctor will reassure the children that no one will come once the procedure is begin, and only a parent or caregiver is available to support the children. And then for this during this preparation phase, the doctor will prepare the equipment and also the children, such as the sterilization, lubricating gel, and also privacy for the children. Next slide. Okay, for the catheterization of boys, sorry, wait a minute, I cannot see. Okay, okay, sorry. Okay, the children, the doctor will wash hands, put on sterile gloves, gently take hold of the penis, such as in the picture, and retract the foreskin as far as possible without hurting the children. So the younger the children, the less this would be. And in a very young boys with tight foreskin, this urinary catheterization might not be possible to be done. And then the doctor will use the sterile gauze swab to clean the glands and also urethral meatus to remove any contaminants. And also the doctor will then apply the sterile local anesthetic lubricating gel to the external urethral meatus and advance into the urethra up to 1 to 2 centimeter if possible. And then the doctor will hold the distal urethra closed and wait for 2 to 3 minutes for the local anesthesia to take effect. And then when the doctor will hold the penis with light upward tension and perpendicular to the child's bodies, such as in upward position. And then the catheter will be inserted. When the first sphincter is reached at the level, which is about at the level of pelvic floor muscles, and also lower the penis, the doctor will lower the penis about 19 degrees. Now the catheter is now in parallel with the body position. So for the step 9 and 10, I will not discuss because this is about when the resistance is persistent and what the doctor need to do. I will proceed with the step number 11, where the doctor will continue gently inserting the catheter until urine is flowing. So after this, move the catheter into the bladder all the way to the hood to ensure the balloon is clear of the urethra. It means that now the balloon must be confirmed to be in the bladder instead of urethra. And then the doctor will continue gently inserting the catheter until urine is flowing. So after this, move the catheter into the bladder all the way to the hood to ensure the balloon is clear of the urethra. It means that now the balloon must be confirmed to be in the bladder instead of urethra. And then fill the balloon with the correct volume of water indicated by manufacturer, and gently bring the catheter back until the balloon is resting in the bladder neck. And then attach the drainage system or catheter valve. And then fasten the catheter to the child, ensuring there is no kink and no opportunity for the catheter to pull on the bladder neck when the children is moving around and mobilizing. It means that you must ensure the position of the catheter and drainage system is stable. And then after this, dispose all the used equipment safely, wash hands thoroughly, return the child to his bed, and ensure that he is being comfortable. Where a drainage system is being used, ensure tubing is correctly positioned to encourage a free flow of urine with no kinks. Next slide. Okay, now we move to the catheterization of girl, where the first three steps is same as during the catheterization of procedure in boys. So I will proceed with the step number 4. With the non-dominant hand, hold the labia minoris apart to expose the urethral meatus. With the dominant hand, gently wash down from just below the clitoris to the rectum with a gauze swab soaked in saline. Repeat 2 to 3 times using a new swab each time to ensure the genitalia are free from any contaminants. Apply the sterile local anesthetic lubricating gel to the external urethral meatus and advance into the urethra up to 1 centimeter. And then wait for 2 to 3 minutes for the local anesthesia to take effect. And then maintaining your hold on the labia minoris, place the tip of catheter into the urethra and insert upward at approximately 30 degrees until the urine flows. And insert the catheter to the hilt before filling the balloon to ensure that no damage to the urethra. Just mean that now it must confirm that the balloon is inside the bladder, not the urethra. Fill the balloon with correct volume as same as the catheterization procedures in boys, and attach to the drainage system or catheter valve. So for the steps number 12 until 16, there are the same steps as the catheterization in boys. Okay, next slide. Okay, now we have the suprapubic catheterization. Why I emphasize on these types of catheterization? Because these types of catheterization is used when the transurethral is not possible to be done, and this is used in the continuous drainage. Okay, so this suprapubic catheterization, also known as percutaneous cystostomy, and a good knowledge about the suprapubic and also the anatomy of the anatomy of the urinary tract is very important to execute this catheterization. So this catheterization is indicated in cases where the transurethral route of bladder drainage or decompression is technically not possible or contraindicated, as I mentioned before. What are the contraindication? So this suprapubic catheterization cannot be done in the absence of any easily palpable or distended or ultrasonographically localized and distended urinary bladder. Next slide. Okay, so for the suprapubic catheterization, refer the picture. So we have 2 types of technique, which is the direct puncture technique and also Seldinger technique. For direct puncture technique, the mushroom catheter, and this is the name of the catheter, is straightened with a stylet and advanced into the bladder. So once the catheter is confirmed within the bladder, the stylet is removed. Okay, next, you refer to the next picture where the Seldinger technique. So for the Seldinger technique, a needle is inserted within the bladder until the urine is aspirated. So in this Seldinger technique, we need to use a guide wire to guide the needle insertion into the bladder, and once the needle is inserted, the needle is removed, and now the one that left in the bladder is only the guide wire. So a dilator is advanced over the wire, enlarging the tract. So the dilator is then replaced with a sheath the guide wire now is removed, and the catheter now will be inserted and placed through the sheath, which is then peeled away. The sheath now now the catheter has no sheath, and the catheter balloon is inflated, and the catheter gently withdrawn until slight tension is felt. Then the catheter is then connected to the drainage system, and now the drainage system also will be secured to the patient. Slide. Okay. For the complication, we have potential psychological problems. That's why in this urinary catheterization, the same gender alternation needs to be done this procedure. And then bladder pain due to bladder spasm, bypassing phenomenon where the urine leaks between the catheter and urethral wall, catheter associated UTI, especially in a long term, and also stricture formation where this is could be due to the urethritis that result from the trauma during incision, also inflating the balloon inside the urethra, and traumatic removal of the catheter. I think that's all. Okay, these are my references. I use online articles and so up to date. Yeah, I forgot. Is there any question?
Okay, good. So what is the name of the catheter again? What do you call it?
Suprapubic catheter and also Foley
That's
catheter.
appropriate catheter lah. Tapi yang the usual catheter for bladder catheterization is we call Foley catheter. Okay, Foley catheter kan. Okay, alternatively in pediatrics, okay, because the difference between Foley catheter and other catheter is first it's soft, and then it's got balloon lah. It's inflatable. Okay, to make it remain in situ. But in pediatric, especially in young babies and young children, we usually use Ralph's tube or nasogastric tube. Okay, we just use nasogastric tube. Especially kalau in out lah. For example, we just want to empty the bladder, so we just inserted the nasogastric tube and then empty the bladder and remove it. But in fact, kalau if you want to keep it in situ pun, we usually use nasogastric tube. Okay, especially in baby lah, small baby. Okay lah. Ada soalan? So what solution do you use as antiseptic? Do you use antiseptic or none?
Yes, we use antiseptic to avoid to minimize any risk of getting urinary tract infection due to the catheterization.
Okay, what antiseptic do you use?
I'm sorry, I'm not thinking about this.
Okay, remember the skin in your perineum is very sensitive and it's very thin. Okay, you don't use alcohol base. Remember, never put alcohol there. You'll get burned. Huh? Apa dia?
Is it iodine? Is it
no,
iodine? Because
iodine is no. Iodine is no. Lidocaine is not an antiseptic. Okay, lidocaine is an anesthetic. Okay, antiseptic of choice is usually it can be anything lah. Sometimes people use octanidine, sometimes people use but most of the time we use chlorhexidine. But in aqueous, we don't put chlorhexidine in alcohol. For antiseptic, for skin antiseptic, we use alcohol base. Okay, because each antiseptic dia punya property lah, dia punya pros and cons. But for catheterization, we don't use alcohol base because it burn. Okay, it will irritate your skin lah, especially skin dekat perineum. So most of the time kita guna chlorhexidine, but in aqueous, in water. But in fact, actually, there's one trial just published, I think last month, end of last month, comparing between sterile water and chlorhexidine in aqueous, 2% chlorhexidine in aqueous for self-catheterization, for CIC, untuk neurogenic bladder. Actually, there's no different because the purpose you irrigate the bladder is actually one of the purpose is actually to prevent the infection, UTI. You have to understand UTI. Most of the time, UTI is caused by the stasis of the water of the urine. So by removing it, you actually reduce the risk of infection. Rather than, of course, there is risk of infection lah by catheterization. Tapi the risk is more if you let the urine stasis in the bladder. Okay, so ada any questions? Any other questions? Tak ada. Okay lah, proceed lah. Next.
Bismillahirrahmanirrahim. So my name is Noriza Zahira binti Zamri, and today I will present regarding the central line insertion in pediatrics. So the central line, also called as the central venous catheter, the indication for this central line is first is inadequate peripheral venous access. For some, if you can get, for example, you can draw blood from peripheral venous access. The second is for peripherally incompatible infusions, such as, for example, the medicine that we use, chemotherapeutic agents. Chemotherapeutic agents can result in inflammations of the veins if we use in prolonged time. So we might consider to use the central venous catheter instead. The third one is hemodynamic monitoring. The more information regarding the hemodynamic monitoring that can be gained from central venous catheter is actually the central venous pressure. And the fourth one is extracorporeal therapy such as hemodialysis. And the last one is other venous interventions such as putting the venous cover filters or putting a pacemaker. Okay. The contraindications otherwise is relative contraindications. The first one is coagulopathy and or thrombocytopenia. All of these are relative contraindications which depends on each situations and the severity of the condition instead. The second one is the site-specific consideration. So for site-specific, we can check whether it has obstruction of the vein by any tumor or mass. So it will be hard to put in the central venous catheter. And the second one is if there is any problem with the vessels or abnormal vessels. We may also not proceed with central venous catheter if the patient seems uncooperative and if we do not gain any consent in non-emergency settings. The central venous catheter insertion, the three most sites to put inside the central venous catheter insertion is actually, the first one is the jugular vein, the second one is the femoral vein, and the last one is subclavian vein. So for this is actually a sterile technique, so adequate preparation is needed beforehand, and the equipment needed are first an ultrasound scanner, the second one is chlorhexidine hand scrub solution, the third one is sterile surgical glove, the fourth one is sterile saline for flushing of the catheter, and the last one is anesthesia. For the solution that is used to sterilize the skin around the site of insertion of the catheter is what I found is actually chlorhexidine plus alcohol. And the anesthesia that is used in children instead of lidocaine, which is used in adult, which is a local anesthesia, we use a general anesthesia instead for children, and it depends, the doses and the type for medications depends on ages. The method or the technique that we use to insert the catheter is actually the Saldinger technique. The first one is, for example, it's artery or vein. We puncture. Okay, since we are talking about central venous catheter, we puncture the vein with a hollow needle, and then after that, we release the flexible guard wire and introduce it into the needle. And after that, the needle will be withdrawn, leaving the guard wire alone, and arterial catheter will be, or venous catheter will be introduced over the guard wire, and then it will be remain inside the vessel until it reaches the destinations. The approaches for gaining central venous access, there are three approaches. The first one is the internal jugular approach. So we approach the patients from the right side of the patient, and we put the patients in the Trendelenburg position, which is 10 to 15 degrees. The head is actually tilted about 10 to 15 degrees. And then at the apex of sternocleidomastoid, we can insert the catheter or the needle there. For internal jugular approach, there is actually 3 approaches. The first one is the anterior approach, where we put along the medial edge of the sternocleidomastoid. The second one is the central approach, where we insert the needle inside the triangle formed by the heads of sternocleidomastoid. And the last one is posterior approach, where we insert the needle at the lateral edge of the sternocleidomastoid. Do inform that if we decide to proceed with posterior approach, it might be hard to use the ultrasound to detect the position of the catheter. Okay. Next one is the subclavian approach. So this subclavian approach is also approach on the right side, and also the patient will be positioned in the triangular position. However, the head will be neutral, unlike the jugular approach before. The patient does not have to tilt his or her head to the left, and the arm will be abducted. So we will insert the needle or the catheter the inferior to the clavicle. And the last one is the femoral approach. So femoral approach is not a method that we consider unless of several reasons. The first one is if it's a temporary hemodialysis catheter, if we can't find access for other primary veins, or during cardiopulmonary resuscitations or certain child emergencies. Okay. And it is done in supine position. So how to find the femoral vein is actually you palpate the femoral artery, and then the vein will be located medial to it. So the complications of this technique, this process, this procedure is actually divided into 3: the medical, infectious, and thromboembolic. And it depends on which approach we use. The complications is different. Okay, the first one is the mechanical. So the mechanical, if, for example, if we use the subclavian approach or we use the internal jugular approach, so pneumothorax or hemothorax might be one of the expected complications. For infectious complications such as local infection, but remember this one is more common if you use the femoral artery approach. And of thromboembolic complications such as thrombosis of the vessel is also common. It's more common compared to if we use the femoral artery approach instead of other veins approach. So this is the comparison if we use the internal jugular approach, the subclavian approach, and femoral approach, or the advantages and disadvantages. Okay. So as you can see, on femoral artery is easier to find as compared to subclavian and internal jugular. So healthcare professional may use the femoral approach to insert in emergency situations to find the artery, to find the veins or artery easier. So I guess that's all. Thank you. Do you guys have any questions?
So where can you insert the central line in pediatric?
Central line, we can insert it through the three approach I mentioned before, or other one is what I saw is PICC, periphery located.
Sorry, what the three sites again?
The internal jugular vein, subclavian vein, and also the femoral vein.
So internal jugular, subclavian,
and femoral vein.
And femoral vein. Okay. The PICC?
PIC in the median cubital vein, I guess.
Okay, PICC can be anywhere lah. The name is peripherally inserted, kan? So it can be any peripheral line. So it's a central line, but inserted from periphery. The central line is defined by the tip of the catheter.
Oh.
So as long as the tip reach at least your SVC or IVC or your atrium, then that's considered central line now. Okay. Remember, cell digit technique is very important. And central line in general, you can also insert in your needs, you can insert in umbilicus, kan? Umbilical catheter. That is also a central line. Yeah. So apa yang nak tanya tadi? Apa tengah sebut central line? Central line in general you divide into two. You got tunnel catheter, you got non-tunnel catheter, kan? So what is the example of tunnel catheter?
I read about it being divided by two, but I'm not sure about the tunnel one.
Okay, tunnel catheter ni macam Hickman, for example Hickman lah. Hickman, you punya chemopod, okay, that is a tunnel catheter. If you go to like oncology ward kan, you'll see patient with a lot of tunnel catheter lah. Tunnel catheter, they can remain longer, they stay there longer. There's no permanent cath. Permanent catheter cuma in pediatric rarely we use lah, usually in adult for dialysis. So tunnel catheter is surgically inserted. Okay, all this catheter is inserted bedside lah by medical lah, by us. But tunnel catheter has to be inserted by surgeon. So you've got you punya chemopod and also you punya Hickman line. Hickman line is inserted into your subclavian vein. Okay, by surgical lah. Okay, itu je lah kot. Ada soalan lain?
Okay, Doctor, may I begin?
Yes.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all of you. Today I will share about the chest physiotherapy and the naso and oropharyngeal suction. Okay, naso and oropharyngeal. Okay, is me Muhammad Zakam Abdul Rahman. Okay, so there is a saying, life is easy. Just breathe in and breathe out. Then repeat. That is life, kan? Okay, so this is my content. Chest physiotherapy and naso and oropharyngeal suction. We go through the facts, indication, contraindications, and methods. And extra for the naso and oropharyngeal, we have the equipment that needed. Okay, so chest physiotherapy. What are the facts about it? It is a treatment to remove excess mucus from the lungs, from the patient's lung. Okay, basically, it is a physiotherapy. So we are expecting from the physiotherapy is the maybe some knocking, etc. Okay, so who is the one to perform this procedure? Those who are the dedicated physiotherapists, or maybe mothers at home. In other words, everybody can do it as long as they have the proper technique to do it. Okay. Okay. So chest physiotherapy have two core in this technique, which is the postural therapy, which means we have to make the patient into certain posture and angles for us to, and then move to the next one is percuss, clapping, and cupping. First, to do the next step is to percuss the patient, to mobilize the mucus from the lungs. Okay, so postural therapy, postural mucus drainage from to drain the mucus from the lungs. Percussion, we usually use the hand like this. It is mainly to build air cushion for the patient, so the patient will feel even more calm lah. Okay, and if the but in neonates or infants, they are too small, right? So we use this. We call this rubber cup. Okay, we can tap cup macam tu. Okay, so the one that we must note that we cannot percuss on the spine, on the breast, on the sternum, on every IV or chest tube, or every fresh surgical site on the chest. Okay, so this is what we must bear in mind. Okay, so the indication, it is for patient with squelettic, tenacious, copious, and located mucus when coughing. Okay, in other words, is those who cannot, who has difficulty to perform coughing lah, kan? So who are they? They are with who are with pneumonia, bronchiectasis, and the cystic fibrosis. Okay. So this is the contraindication. Those who have the bleeding tendencies, postural discomfort, history of hemoptysis, a recent history of hemoptysis, and rib fracture. However, all of these contraindication are very relative. In other words, most of the patient will not have any problem to perform to perform this physiotherapy. Okay. Okay, so so this is the method. It is very easy actually. First, they have the certain posture, and then we proceed with the percussion and vibration. Okay, so let's see. This is the description. For the A one, we have the actually we percuss the patient. It is based on the lobes of the lung. Okay, which are the targeted lobes. So there is where we will percuss. Okay, so the one is the upper lobes. We can lean the patient forward 30 degree, percuss between the collarbone, okay, and the shoulder blade, and the scapula, on each side of the chest. Sorry. Okay, then okay, the one that I prepare here is for neonates and infant. Okay, for children, the procedure is like the adult. Okay, so the upper lobes you can lean the patient about 30 degree, percuss between the collarbone, the clavicle, and the nipple. Okay, on each side on the chest. Then we have the lower lobes. We can percuss. We can position the child's head down, down about 10 to 20 degree, lying on the right side. Percuss on the left side, below the underarm. Okay, and then the lower lobes too. We can position the child's head down about 10 to 20 degree, lying on the left side. Percuss the right side below the underarm. Okay, so so the common question lah, how are we going to position these children? Okay, see, they usually use pillow lah. Usually use pillow, or the mom's punya riba, kan? Here lower position head down 10 to 20 degree, lying on the abdomen. Percuss between lower edge of the rib cage and behind the underarm on each side of the spinal cord. Okay, at the back side lah. Okay, the body, then the lower lobes too, we can position it 10 to 20 degree also, and lying on the back, percuss in front of the chest, in nipple area, and just below. Okay, so then this is how we percuss. That is the position, right? So this is how we percuss. Percuss the lung area, cover the chest with thin layer of clothing. This is to make the patient even more calm, to calm the patient, and secondly is to reduce the tension between the cupping and the patient's skin. Okay, then perform PCT, physiotherapy chest physiotherapy with cup hem or rubber palm cup. Okay, this is for baby, for infant. The cupping action build an execution between the palm and chest wall. It help the patient to calm, and then while on each percussion we have to vibrate a bit. Okay, and remember, never do percussion on spine, breast, sternum, IV, chest tube, and fresh surgical sites on the chest. Okay, percuss the patient about 3 to 5 minutes. And however, physiotherapy is meant to help the patient. And our physiotherapy will be pointless if the patient do not try to cough by themselves. So we must encourage the patient to cough. Okay. So that's it. So move on to the nasal and oropharyngeal suction. Nasal and oropharyngeal suction is technique used to remove excessive mucus using a catheter from the upper airway. So what is the difference between the chest physiotherapy and the oropharyngeal suction is this is one they use the catheter, which is this everybody cannot not everybody can perform this. Only the decoder operator lah, such as the pediatrician and MO, etc. Okay. Also, this is the equipment that we need. We need this is the rigid suction catheter or OPA. We call this oropharyngeal airway. Okay, then we need the PPE, all the PPE. See the we also need the face shield. Okay, so we have we need a latex glove. We need suction sauce. Okay, every time we suck the mucus from the lung. We have to place it suction sauce, and then we have the lubricant to insert the tube into the airway. Okay, and then we have the soft suction catheter. This we use through the nose, nasopharyngeal airway. Okay, this is for use for through the mouth. This we use through the nose. Okay. Then the indication who need this, those who are with thick mucus secretion retention condition, and is performed to stimulate cough and to obtain sputum sample. Okay. And the contraindication, those who have the bleeding disorders, epiglottis, laryngospasm, esophageal fistula, recent esophageal surgery. Okay, different from the previous one. This is only recent esophageal surgery is the relative one, while the other four is the absolute. Most of the time it is absolute. Okay. Because bleeding disorders, it can lead to excessive bleeding, epiglottis, laryngospasm will lead to the respiratory distress, etc. Okay. Okay, so we go one by one. Nasopharyngeal route. Okay. Actually, in the suction, we have about 3 methods: nasopharyngeal, oropharyngeal, and the third one is the tracheostomy. But however, tracheostomy is rarely done lah. We usually done the oropharyngeal and the nasopharyngeal route. Okay, so the nasopharyngeal route through the nose, we must correctly insert the nasopharyngeal airway or the soft suction tadi, lifting the nares to reveal the nasal airway and advancement to the NPA parallel to the nasal floor. Okay, gently rotate the NPA. Then if the resistance is felt, okay, it should also rotate easily when correctly placed. Okay, make sure the NPA is correct, is placed correctly. So how to make sure it? You can keep on rotate it 180 degree until you feel the resistance. Okay. So the resistance, I mean the mucus lah. You feel the mucus. Okay, suction performed via the NPA. Lubricate the catheter prior to the insertion to ease the insertion procedure. And then the oxygen can be reapplied while the suction catheter is still in the patient's airway. If copious secretion are present, desaturates occur, or to give the patient a rest during the procedure. Which is in other words, we must keep the patient in a very stable condition, not in the stress condition. Okay, and the other one, we have the oropharyngeal route. Choose the correct oropharyngeal airway size. about 1/3 of the trachea. Okay, we must first measure lah. We take the OPA, we put here. Okay, then we measure about 1/3 of the trachea. Okay, then position the OPA upside down, insert the OPA gently. Okay, insert it gently, then rotate and insert the OPA about 180 degrees until feel the resistance. Okay, the resistance is referring to the mucus. Begin the suction for 30 seconds. Okay, then usually it will resolve lah. After that, if needed, repeat the procedure. Okay, so I have prepared 4 videos actually, but I will share about 2, and I will okay lah, sekejap. Can you guys hear this?
Can.
Okay.
And now we're going to do infant CPT. I typically like to demonstrate on my
This
dog
is
while
for the
my husband
infant.
demonstrates on the baby. I always say that, you know, I make it look a lot easier because I just have a dog within a certain position. The awkward part about CPT is just getting them in the proper position. It is important to make sure you percuss in the proper areas and for the right amount of time. Maybe 2 minutes in each area. So I'm going to go through and demonstrate on my dog while she demonstrates on Brody. Typically, you want to make sure they haven't had anything to eat half an hour prior to CPT. You always want to have some clothing to protect their skin because it's very sensitive. You don't want to percuss over their lower ribs, their spine, or their stomach. So the first area I do is right above the nipple line below
See, they
the
use
shoulder.
the pump cup,
With infants, you have to
rubber
do
pump
one
cup, okay,
area at a
for the
time.
infant and baby. Infant and unit.
Here we go. There we go. There we go. Yay. Yay.
Below the clavicle,
So 2 minutes here, 2
between
minutes over
the
here.
nipple
So while they're
chest.
setting up, I go ahead and I do the
Chest
back side
nipple.
as well. So kind of lean them forward, and you're going to do taps on the back.
Mm.
Ooh, what do
At the
you
back of the
do?
scapula.
Baby off.
Always remember not to
Yeah,
touch the
strap them, keep
spine.
them entertained. Oh, good job. Yay. So then I go ahead and I lay them down, which he's getting to be a big size, so he could probably lay down on a bed. What's going on? So you're going to do below the nipple line and above the end of the rib cage.
Under,
Brody.
under the forearm.
Here. For 2 minutes on each side. Roll over to the side. Oh, it doesn't matter which side you start with. I do. I make it look really easy. I know. Hey, Ruby. So you're going to be directly under the armpit. So 2 minutes. And then you do what we call a quarter turn back. So you have to lean back and back. Just like Ruby's doing. Yeah, perfect. Good job. Yay. Yay. And then we do the other side, which is going to be easier said than done. Exactly like that. Wow. Where are you going? What's the matter? And infants definitely want to keep their arms down. They do not like to pull them back. Hi there. And then a quarter turn back. And then the last area we do, we have them lay on their belly. You're going to percuss on the lower part of their back. Yay. So 2 minutes on each side. Good job. Yay. All right. So real quick review of my dog. So 12 areas. 5, 6, 7, 8.
So okay, we will fast forward and we get at 1.5 fast forward.
The non-intubated patient. Introduction. Or to stimulate a cough in a patient who doesn't have a good cough, or review the equipment that you will need, complications of suction, as well as often you may not be able to the lungs. You observe any cortical secretions may also be candidates for this procedure. That is up at 30 degrees, as well as make sure that you have oxygen nearby in case the patient has any complications, and have your suction source ready. I'm now going to wash my hands and get my gloves on. I'm going to wash my hands with an alcohol-based hand sanitizer, or you can wash with soap and water. I'm going to go ahead and use a size 5-6 soft suction catheter to suction this baby. You might use a larger catheter such as an 8, 10, or 12, depending on the size of your patient.
Point of clarification, size catheter for thin air. This will allow the catheter to be large enough to remove secretions, but not so large as to obstruct the airway.
I'm going to remove my catheter and keep the tip clean until I put it into the patient's nose. I'm going to hook up my suction to the catheter, and I'm going to test the suction to make sure that it's not too high. That's just right. I'm also going to loop. I'm going to get ready. I'm going to have the patient prepared, and I'm just going to hold on to this baby's head a little bit just so the baby doesn't try to wiggle away from me. And before I start, I'm going to measure from the baby's nose to ear to get an approximation of how deep I'm going to suction on this baby. And that's about at the 10 mark. And then I'm going to prepare, if a parent is with the child, prepare the parent as well as the child. I'm just going to hold on to this baby's head just so that the baby doesn't shake their head and try to avoid the suctioning. I'm going to gently insert the catheter without any suction applied. I'm going to put the catheter in, and if I need to, I'll twist the catheter just a little bit to help it go down. I'm going to get to about that 10 mark, and then I'm going to apply suction and continuously apply suction as I remove the catheter. As I remove the catheter, I want to note the color and consistency of the secretions and whether there's any odor.
Point of clarification. Duration of suctioning. Please note that you should limit each suction to 3 to 6 seconds.
I'm going to give the patient a rest period of about 30 seconds to recover from this nasal suction before I begin to suction again. If the patient didn't cough, you might want to try to go in the other nair, or maybe go just a teeny bit deeper to stimulate a cough if the patient in fact is able to cough for you. I'm going to go down one more time now and roll the catheter on the way out as well.
Procedure, oral suctioning.
Suction after you have nasopharyngeal suction the patient, or you may just go again, you want a rigid catheter that will be better for getting more thick oral secretions. Again, you want to make sure that the suction is not too high to not cause any trauma to the mucosa of the mouth. For oral suction, again, if the patient is non-cooperative, you may just need to gently guide their head to keep them from trying to move their head away from you. Just go ahead and apply the suction into the side of the mouth and apply suction, and then go around to the other side. Try to get under the tongue and a little bit up over the tongue, and try to get, it's just been fed, due to you don't want them to gag and then vomit any feeds that may still be in the stomach.
Complication spasm to the oral or hearing or patient's.
So that's it. Okay, thank you. Okay, do you have any question?
Any questions?
Yeah.
Okay, next. Proceed lah. Sorry, topik yang bosan lah. Saya tak suka topik. Okay. Tapi this is very important lah. Actually, bila kat ward, kalau you know how to do chest physio, that's advantageous lah. Because most people tak pun.
Bismillahirrahmanirrahim. Assalamualaikum. Can you hear me and can you see my screen?
Yes.
Okay, thank you. Inshallah, today I'll be presenting on the procedures of ECG in pediatrics. So this would be my contents. I'll be explaining a little bit on the indications, the common settings of the ECG, the lead placement, and also the common findings in pediatrics ECG. So these are some of the indications for ECG. It can be due to the patients having syncope or seizures, any episodes of seizures, cyanotic episodes, chest pains, or other symptoms that is related to exertion. It can be due to drug ingestion, rheumatic fever, or Kawasaki disease. So these all diseases are related to the diagnosis and also the management of the disease themselves. So patients that are diagnosed with rheumatic fever, Kawasaki disease, pericarditis, and also myocarditis are indicated for ECG. Also, patients with myocardial contusion, congenital heart diseases, which is quite common for patients to have septal defects, infants with family history of heart attacks or sudden death can also be indicated for patients with electrolyte abnormalities like hypokalemia, hyperkalemia, patients that has undergone cardiac surgery, patients with hypothermia, and also tachyarrhythmia or also bradyarrhythmia. Okay, so this would be the common settings for the ECG, which is the recording speed or the paper speed is calibrated at 25 millimeter per second. Sometimes on certain settings, it is also done with 20 millimeter per second, but 25 is more common and it is used in pediatrics. And for standard ECG calibration, it is usually 10 millimeter per millivolt, which means every one small box over here, which is size 1 millimeter times by 1 millimeter, equals to 0.04 second, and also the height of 1 millimeter box would be 0.1 millivolt. So this is the common ECG lead placement, which is the most common one, 12 lead ECG. So we have technically 6 lead on the chest and also 4 on the limbs. So for pediatrics, it is common for us to put the limb leads at the shoulders and also near the hip joints. Why we don't put, or why it is not usual for us to put it on the hands or arm and the legs, because pediatrics patients, we call babies and infants, are hard to be to stay put or to stay calm, and therefore by putting the limb leads on the shoulders and the hip joint or near the hip joint, we can minimize the movement and also minimize the electrical signals misconduct. And then, so as usual, V1 until V6, V1 at the fourth intercostal space to the right of the sternum over here. And then for V2, it's the same as V1, only on the opposite sides. And then we can see V4 on the fifth intercostal space at limit clavicular line. This is our apex beat located at. And then V3 is directly between this V2 and V4. We also have V5 and V6, which is on the same line with V4. But on this image, it's not on the same line, but it's supposed to be on the same line. V5 at the left anterior axillary line. So the mid axillary line is under our armpit. So the anterior axillary line is on our anterior part of the body, just nearby our armpit. So but on patients that have limited intercostal space, or we all know that on babies, it is quite difficult for us to find the intercostal spaces or the rib spaces, and therefore we apply this kind of method or guide to put or to place the ECG lead. So V1, nipple line to the right of the sternum. So over here, this is the sternum, the right about half inch from the midline. So this is the midline, half inch. Nipple line, which means it is at the upper of the nipple, and V2 always opposite of the V1 lead, left of the sternum, also half inch from the midline, and then V3 also the same, midway between V2 and V4. You see V4 below the nipple at the mid-clavicular line, slightly medial. Usually for V4, if it is possible, we would put the lead under the nipple line inferiorly, or if it's not possible because of the V3 lead, then it would be a little bit medial, the opposite of medial. Opposite. Not medially lah. For V5 and V6, it's also the same level as V4, same level as V6 as well. But V5 and V6 would be below the armpit, which we cannot see from this image. V5 is also at the anterior of the axillary line. So we can see there is about 4 ECG leads over here, 4 wires, but it's not clear. I'm so sorry, but I can't find any other image. So when we carry out ECG on pediatric patients, it is very common for us to see right axis deviation. So this is due to the high resistance in pulmonary circulation when in newborn, especially during the developmental phase. The lungs are not used. Therefore, the right ventricles would face a larger resistance and therefore would be enlarged or would be hypertrophic. So when the patients are right axis deviated and also having right ventricular hypertrophy, patients are also common to be found with large R waves in V1 until V3, and also we can see the T wave is inverted in V1 until V3 as well. And for most pediatric patients, or even most pediatrics, not only patient, they have shorter intervals, especially the PR interval and also the QRS interval. And every infant, every newborn has a faster heart rate, and heart rate drops during their growth. So over here is the axis. So we can see full-term newborn, it's the average is 135 degrees positive, which is a right axis deviation. And after during their growth, the axis of the heart would continue to the left, would continue to deviate to the left until it is normal in during adulthood. So this is an example of a pediatric ECG. This is a common, this is a normal 1 week old infant. So as we can see over here, let us first see the heart rate. So the distance between these two peaks is approximately 2 large boxes. And the heart rate is quite stable. So 300 divided by 2 large boxes would be 150. Therefore, the heart rate of the patient is 150, approximately 150 beats per minute. And then we can see the large R wave over the V1 until V3, very, very large wave. And then we can see on the lead 1, it is inverted or negatively inverted. And then we can see on the lead 2, it is positively inverted. And then on the AVF, it's also positive. So when lead 1 is negative, lead AVF is positive, we can say it is right deviated, unless proven otherwise by other leads. So we can also see that the T wave is inverted over here. The T wave is inverted, same as this one. The T wave is inverted, and also this one. All of the V1 until V3 T waves are inverted. Okay, so this would be the heart rate for infancy, for children. Newborn less than 1 week would have a maximum heart rate of 160 beats per minute. And then for adult, as what we all know, it would be 60 to 100. And therefore, it is very common for pediatric patients to have a very high heart rate due to their own high metabolism rate. So the heart rate is also going to decline time by time during their growth to become an adult. I have a YouTube video, but I think you guys can watch it on your own. It's very simple yet very informative. And most of my pictures, this one and this one, are taken from the video itself. That's all from me. Thank you. Are there any questions?
Okay, I've got one question. Okay, what is sinus rhythm?
Sorry, doctor.
What is sinus rhythm? Tak dengar eh?
Sinus rhythm. Sinus rhythm is regular rhythm.
Ya ke?
Sinus.
You guys buat medical kan? You guys year berapa? 3, third year kan?
Yeah, year 3.
Oh, so mesti dah buat basic sciences kan? So what is sinus rhythm? Lemak.
Bukan
By the way, ada presentation lagi ke?
ada satu rasanya.
Doctor, a sinus rhythm, is it electrical activation begin at SA node?
Yes, so that's very good. So bila orang kata what is sinus rhythm means a rhythm that is initiated by your SA nodes. Okay. So what other tissue can actually generate impulse besides SA nodes? Besides SA nodes, apa lagi?
Our brains.
Mana boleh brain generate impulse? Ni dekat heart lah, heart. What is your conduction tissue besides SA nodes? Kalau SA nodes your problem, if you got problem with your SA nodes kan, contoh heart block. So what are where the impulse will be generated? You ada AV nodes kan? Okay, you have to imagine you ada SA nodes. SA nodes should play the role of generating impulse. Okay? And it will generate sinus rhythm. If SA nodes problem, got problems, conduction problem, or anything, so AV nodes will take the role. Remember, AV nodes is more rapid than SA nodes. And AV nodes is called junctional rhythm. So AV nodes punya rhythm is called junctional because it's actually at the junction between atrium and the ventricle. So it's called junctional or supraventricular. Faham tak? So what is the characteristic? Is higher rate. So when we talk about supraventricular SVT kan, we talk about SVT, when we talk about junctional rhythm, we are talking about rhythm that originates from AV nodes, not SA nodes. Okay, faham tak? Faham kan? Tapi kalau AV nodes you problem juga, SA nodes problem, AV nodes problem, no conduction from this area. For example, you ada heart attack kan? In adult, you ada heart attack, you kena anterior infarct. Kan? Anterior ataupun anterior septal infarct. Which affect you punya conduction dekat from AV dengan SA nodes. You akan dapat apa? So what are the tissue that can generate impulse? It's actually your ventricle. So your ventricle will take role of your SA and AV nodes and it will generate impulse. So impulse daripada ventricle kita panggil? Kita panggil ventricular rhythm. Ayo. SA nodes kita panggil sinus rhythm. Kalau daripada AV nodes kita panggil junctional ataupun supraventricular rhythm. Okay, it doesn't matter lah. Kalau you ada WPW for example kan, you ada WPW that affect you punya conduction dekat bundle of his kan. You punya conduction dekat bundle of his. Bukan pekerja, dekat bundle of his. So dia akan bagi alternative pathway yang cause WPW. And this alternative pathway is actually above your ventricle. That's why WPW dia cause SVT. I thought you faham tak apa yang cakap. Tapi later lah kalau kita jumpa boleh lukis. I'm very interested in this physiology of your heart. So basically kalau AV nodes you tak works, SA nodes tak works, AV nodes akan take over or alternative pathway, supraventricle dia akan take over, so you call SVT. Dia akan cause SVT. Kalau this AV nodes tak work juga, ventricle will take over, you akan cause ventricular tachycardia. Because ventricle dia lagi laju daripada SVT, actually is lower than SVT or can be lagi laju daripada dia punya AV nodes. and it's more powerful. Tapi problem dia ialah it won't give chance to your atrium untuk refill the blood. So VT and VF usually akan affect you punya output, cardiac output, and you akan mati lah kalau you tak buat apa-apa. You cannot live long with VT or VF. Tapi you can live long enough with SVT. Cuma problem dia bila laju sangat, dia akan cause thrombus formation. So you akan dapat stroke lah. Kalau you biar je patient with SVT. And also dia boleh dapat tired kan, heart become tired, so dapat cardiomyopathy, dapat heart failure. Okay, that's why you have to understand. Sinus rhythm bukan P followed by QRS. This is nonsense, man. P followed by QRS. Apa yang P, what is QRS? No. Sinus rhythm, kalau contoh you punya ada doctors kan cakap dengan you, oh sinus rhythm is P followed by QRS. What is P? What is QRS? That's just image depict by your ECG. No, you should not answer that. Okay, you boleh lah answer as medical student, you boleh lah answer sinus rhythm is P followed by QRS. But a doctor should not answer that. Okay, because sinus rhythm is a rhythm that generated from your SA nodes. Okay, remember sampai mati, okay? Kalau I jumpa you guys as a doctor, I tanya what is sinus rhythm, you jawab P followed by QRS, then I rasa you are tak qualified to be a doctor. Okay, so tu number one. Number two is, again, you correctly mentioned about the pressure kan, about the high pulmonary pressure in units kan, in children, young children, that actually leads to the right axis deviation. Okay, lagi satu, you have to understand ECG lah. If you understand your ECG kan, you can draw the heart. You boleh tahu heart you macam mana. You can draw which part of the heart is enlarged, which part of the heart is hypertrophic, and which tissue of the heart actually generating the impulse and where is direction of impulse. You tahu kan, kalau P tu upward, kalau any of the wave is upward, outgoing, it means it move towards that. Faham tak? Tapi if downgoing, it move away from that. Kenapa P followed by QRS? Because P is upward, means the impulse is generated from SA nodes and move away from SA nodes. Faham tak? P is SA nodes. Okay. Faham kan? P is not SA nodes, P is actually atrium. So kalau P dia upwards means impulse tu datang daripada atrium, move away from atrium. Kalau P downwards, maksud dia the impulse, the atrium, the impulse is coming away from the P. Coming towards atrium. Maksud dia mesti datang daripada junction ataupun dia datang daripada ventricle. Faham tak? Tapi problem dia usually impulse yang generated from your AV nodes or generated from your ventricle is higher in amplitude. Dia akan overshadow you punya P. So you akan nampak tak ada P. It's actually there's P, tapi P inside your QRS. Okay, it's very interesting lah ECG ni. Tapi tengok kalau you guys interested, maybe itu boleh belajar. Anyway, so ada satu again. Last kali apa?
EEG.
EEG Ayo, bosan lah EEG. EEG is very complicated. Actually, I have to say sorry because I will realize I've got meeting now.
Oh, betul.
Tapi because this meeting dengan Bangladesh punya group, so saya tak boleh nak postpone lah this meeting. But the rest tu kita postpone next session. Next session bila?
Next Wednesday.
Next Wednesday. Yang tu ada berapa procedure? Plus the blood CNS?
Seven, tak silap betul.
7. So ada 8 lah semua. Okay, tak apa. So next session kita akan plus blood CNS dengan EEG. EEG is very interesting. EEG dan ECG ni sama je konsep dia. Cuma EEG is more difficult lah to interpret. You ada alpha, delta, semua benda dengan But I didn't expect you guys to actually explain on the alpha, beta, delta semua tu. Tapi so next session kita akan ada 8 procedures. So try to fix one presentation 5 minutes. Boleh tak? Okay, I want only 2 or 3 slides per presentation. Just mention the most important step or the key point. And better kalau ada video, satu video je. and that's it. Kalau ada diagram, just a diagram, a flow chart, and that's it. 1 or 2 slides should suffice. This is just a procedure kan. Procedure you should do it lah rather than you explain it. So boleh tak?
Doktor, untuk EEG, apa yang doktor expect untuk procedure presentation?
EEG just a procedure. I don't care about the interpretation.
Maksudnya
I
ada
did learn
electrode
lah,
placement ke?
Yes. Just the principle of the electrode placement. Dia ada banyak EEG tau. Dia ada EEG ada 30 leads, ada yang 36 lead, ada yang 70 leads. Just basic. You kena tahu lah. You kena tahu right left, and then kat mana you nak letak frontal, occipital, parietal, and then invoke EEG dengan sleep EEG. Just the type of EEG, and then macam mana you nak procedure, you nak sedate patient ke tak nak sedate, what of provocative test yang you boleh buat. Just basic that, not the interpretation lah, just the basic procedure. Okay, I need to leave.
InsyaAllah.
Okay guys, okay, thanks. Okay, kita tanggung dengan atas speaker for markah, nanti you text me lah markah. I've got the marks now, tapi nanti lah. Okay. Kita tasbih tanggung atas speaker for nas surat nas. Okay, assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.